Welcome, digital pathology trailblazers. Today is the 10th DigiPath Digest. I'm super excited. I'm gonna wait a little bit for you to join. And okay, we are supposed to be live through live stream. If somebody registered and I see you guys coming in, say hi and let me know where you're tuning in from. So, here I have special banners prepared for you today. So if you are here, let me know where you're tuning in from. And we are supposed to be on StreamYard, Facebook, LinkedIn, YouTube. I'm getting a message that we are having trouble doing this on Instagram. Maybe I need to do something on my phone. Let me check if I need to click there, go live. Guys, always something. Live. Now you can go live. We should be going live on Instagram. So I'm just gonna, just in case, I'm gonna put my phone here. I'm supposed to just click that I'm live on Instagram, but we'll see. Okay, welcome everyone. And yeah, so great to have you. Hey, hello, welcome India. Okay, I think Instagram is solved. I'm not sure. I think it's solved. Okay, guys, so it is our, and I see hearts liking, everybody is liking, fantastic. Whenever you join, let me know where you're tuning in from. And let's start with a few announcements. I'll correct my phone here for Instagram. Okay, so the book, right? I don't know if you guys know that I have a book. It's called Digital Pathology One-on-One. And I just checked, and you know how many people downloaded this book? It's a free PDF on my website. So if you want to get it, you go to digitalpathologyplace.com, and then there's going to be like a button. You click it and you get the book. 1,693 people downloaded the book. So if you have not downloaded it yet, it's right there available for you. And so you can go there anytime. And here I have comments. Okay, so guys, it is the 10th DigiPath Digest. It means we said at the beginning that if I get to 10, if I stay consistent, I get to 10, I'm going to get myself a new tablet to reviewing the papers. Currently, I'm working on a Lenovo tablet, which is fine. You know, you can draw on it and it's fantastic. I was thinking of a Wacom or something else. We'll see. Next week, I'm not going to be here. This is the last time I'm broadcasting to you from this office of my cousin in Poland, because next week on this day, on our broadcast date, I'm going to be traveling back to the US. So, and I see more people joining. Let me know where you're tuning in from. Say hi and let me know where you're tuning in from. So last time from Poland for this particular time. I'm going to be going back to Poland, and this is the beauty of digital pathology, that I can actually do it. I can download my digital slides and work from here. So that's one update. Because we kind of did our, like the first part of every endeavor for me is, okay, I show up, we show up. And you showed up every single day for this DigiPath Digest already 9 times, today the 10th times, and I see people coming in, so say hi whenever you're joining. And so we show up, right? I show up, I have our abstracts and everything. So we kind of like are past the hurdle of showing up, I'd like to believe. The next thing is to get better. To get better for me specifically. What does that mean? That I will be preparing more for this. I'm going to try to make this content better. I'm going to try to dive maybe on my end deeper into the papers that we're into, the abstracts that we're reviewing. For you, it's probably going to stay in the same form, but I will be more informed about the paper because I will go in and research everything that's not so clear from the abstract, and sometimes it's not so clear. Welcome, Monica. Hello to Edinburgh. Monica is a regular as well, and she was a guest on my podcast. So if you want to listen what she has to say about digital pathology in clinical trials, it's also on the Digital Pathology Place website. So for me, stepping up the game past showing up is going to be getting better in reviewing those papers for you. And I'm gonna, because those episodes are also on the podcast. A quick update on the podcast. I just, together with my team, we just submitted the podcast to YouTube as audio as well. So Google Podcasts, if anybody was listening on Google Podcasts, doesn't have the podcast option anymore. They kind of integrated into YouTube Music, which is a little bit confusing because then those audio episodes show up on normal YouTube as well. But whatever. People sometimes just listen to stuff, and those who were listening through Google Podcasts now have this available through YouTube Music, and we have this podcast available through YouTube Music as well. So I'm going to keep putting it out as an audio podcast only, and I'm going to leverage AI to edit all my ums and ums and the clumsiness and the ands that I overuse. And again, there is a tool that I'm going to show you later. But let's dive into the abstracts. Oh, we have guests from Pakistan. Hello, welcome, Pakistan. Anybody from the US today? They might not be joining because it's the beginning of the long weekend. Well, actually not yet because it's still Friday, 6 a.m. EST. But if somebody joins from the US, let me know that you're here at 6 a.m. EST. So let's dive into our first paper, and then based on this paper, I'm going to show you a cool tool. And thank you so much for the likes, for the hearts. And whenever you do that, it takes us to more people who might want to benefit from this. And I can like wave at people on Instagram. Welcome, Instagram. Okay, so I hope on Instagram you see the screen. Oh my goodness, Robert, you're here. I missed you last time. I didn't see you last time. Robert is joining from Boston this time, not from Maine. So you're at the conference or somewhere, or headquarters. Okay, let's start. The first paper, and I have them all marked in green, the ones I want to talk to you about. Sexually dimorphic computational histopathological signature, prognostic of overall survival in high-grade gliomas via deep learning. This is from Science Advances, and I checked. The impact factor is 11, decent impact factor. Ruchika Verma et al. And this is from a group from New York, Mount Sinai, and also Cleveland Clinic, Cleveland, Ohio. So here they say, high-grade glioma is an aggressive brain tumor. Yes, it is. And sex is an important factor that differentially affects survival outcomes. And they used an end-to-end deep learning approach of H&E scans, and they identify sex-specific histopathological attribute of the tumor microenvironment and created sex-specific risk profiles to prognosticate overall survival. And they had a two-stage approach using ResNet 18. This is a deep neural net for image analysis. And they had this two-step approach. So first, they segmented the viable tumor region, and second, they built a sex-specific prognostic model for prediction of overall survival. And they used the C-index, concordance index, as their performance metric, and it was because they had six different models or several different models. That's why they have so many, like 4 of these concordance indexes, all around 0.7, both for females and for males. For males, yeah, more or less 0.7 C index. Across training and 3 independent validation cohorts. Okay, wrong, not different models, but different validation cohorts. So for all the cohorts, they had a separate C index. And what does that mean? It means that end-to-end, the deep learning approaches using routine H&E slides trained separately on male and female patients with the high-grade glioma may allow for identifying sex-specific histopathological attributes of the tumor microenvironment associated with survival and ultimately build patient-centric prognostic risk assessment models. So everybody wants to have this specific to patients, right? Whether be it specific to female versus male, different demographics, different, I don't know, different race, different patient cohorts. They are not all the same. So here they did for male and female. But what I wanted to show you is this new tool. Did I tell you that I discovered a new tool today? It's called let me check. It's called exactly Space. I need to show it to you. So let me unshare this one and share the might remove this one. Present. Stop screen. Present. Give me 1 second. Share screen. Okay, and we should be able to. Okay, you guys should see my screen right now. I'm gonna move it. No, okay. You should see my screen. And bear with me as and Instagram people, if you don't see it on Instagram, go to LinkedIn or YouTube. YouTube is the best. And sorry to get you off of Instagram. But, okay, so we have this Science Advances, and the tool that I'm talking about is called Space, and I already installed it as a plugin for Chrome. I just want to, and in the short words, it lets you chat with this paper. So we just reviewed the abstracts, right? And when I was reviewing it, I'm like, okay, what is this C index? So basically, especially it works very well if you can, if you have the full paper available, because if you only have the abstracts, it's just going to base the answers on the abstracts. And what is it? It's like an AI chatbot to chat with the content of the paper. I'm just checking. Yeah, we have everything. We have the full paper is available. And let's do this. What is C index? Because we have always different metrics in those papers, and when I prepare it for you, and I'm like, this came from the universe to me when I'm like, I need to dive deeper into those papers so that you don't have to, and you just come out of this session with actionable information without having to go and Google stuff, right? So here, understanding C index. The C index or concordance index measures how well a model's predict risk scores correlate. Models predicted risk scores correlate with actual survival times. And it ranges from 0 to 1. We kind of knew that, right? 1 indicates perfect prediction and 0.5 suggests no prediction. So we had 0.7 around. So the next question is is the C index in this paper good? Is it good that it's 0.7? Is it a good thing? So The C-index values reported in this paper are generally good, indicating effective model performance. For the female cohort, 0.696 to 0.736, a C-index above 0.7 is typically considered acceptable, suggesting that the models can reliably differentiate between low and high-risk patients. Fantastic, right? I love it. And anything else that we would like to? Okay, what I want to know what features they identified in this tumor microenvironment that were specific for males and specific for females. So let's ask it. What histomorphological tumor microenvironment features were specific for males versus females? It's just makes life so much easier whenever you read papers. And I'm talking to people from what is this called? Sorry, it's new. So from SciSpace from the company. Let's see if we can do some kind of collaboration. So here we have it. In males, high-risk patches were associated with microvascular proliferation, pseudopalisading cells, and in females, high-risk patches were linked to infiltrating tumors. What infiltrating lymphocytes maybe, and MVP, which is the microvascular proliferation as well. Low-risk patches in males were related to the peritumoral region, where in females they were associated with stromal regions. So it's going to tell you all these things from the paper. And if this is something you're interested in, it's called SciSpace. And I have a free account, so you can sign up for a free account. And if SciSpace decides to work with Digital Pathology Place, then I'm going to bring you a better, more in-depth tutorial. For me, it was a cool way to interact with a paper leveraging AI. You guys know that for me, AI is leverage. So let's go back to our normal papers. If you have any questions, let me know in the chat. Let me know in the comments. I see comments mostly from LinkedIn here. If you are on YouTube or somewhere else, let me know that you're doing it there. And I'm going to share the other screen here. We're back to our screen sharing. Okay. So that was it. Our next paper is a digital tool supporting pathology practice and identifying leukocytes. So that was an interesting one. So it's in a journal called Study of Health and Technological Information. I checked this one and I should have had it noted somewhere, but this one was impact factor less than 1. So and there, I think they might have had a series of different papers on digital pathology, because I have a bunch, but I'm not going to be reviewing a lot of them. But 1, 2, 3, we're going to look at 2. We're going to look at this digital tool supporting pathology for, leukocytes. Okay, so Dumitru Cristian Apostol et al. From Romania. They wrote, they wanted to deliver an all-in-one package that contains both the part where pathologists can manipulate the data as well as predefined models. And this was supposed to provide the numbers of leukocytes and the mass of the cell, which is interesting, okay, only from the image with minimal intervention from the pathologist. They did this as a prototype, as a proof of concept. And the models correctly identified 89% of the actual positive instances. This tool provides visual scripting, reducing the learning curve for pathology analysis techniques. I mean, I would not want to interact with. So visual scripting, I also checked. I use the SciSpace to confirm that visual scripting is like a kind of a programming language, but like with pictures and not coding. I would want to have it even more streamlined than visual scripting. I would like to have a user interface and click on stuff rather than do visual scripting. But now you can use this tool. Well, it was a proof of concept, but it's for lymphocyte quantification, and that was there. Our next paper is assessing the performance of deep learning for automated Gleason grading in prostate cancer. So Gleason grading, we're talking not just like prostate cancer detection, which there is an FDA cleared algorithm for that. But now we're talking about grading, and this is a group from Augsburg, Germany, Dominic Müller et al. And prostate cancer is a dominant health concern, calling for advanced diagnostic tools and utilizing digital pathology and artificial intelligence. This study explores potential of 11 deep neural network architectures for automated Gleason grading in prostate carcinoma, focusing on comparing traditional and recent architectures. So they used a standardized image classification pipeline based on the ArcMedi framework, and this facilitated robust evaluation using an in-house data set consisting of 34,264 annotated tissue tiles. And we know that tiles are not slides. We're talking about little tiles. And let me do this. Let me leverage this. I want to tell you what this ArcMedi framework is. I wanted to leverage the tool, but I don't have it set it up on the screen. But this ArcMedi framework is an open source software that allows fast setup of medical image classification pipelines. So it's for image analysis scientists that need to set up a pipeline how to analyze images. So they use this framework. And what did they state? So they investigated 11 deep neural network architectures, and they had varying sensitivity across architectures, and they had ConvNext, some convolutional neural net that they called ConvNext, demonstrating the strongest performance. And they say newer architectures achieved superior performance, even though with challenges in differentiating closely related Gleason grades. So what do I understand here? I'm glad that newer architectures achieved superior performance than older. So that means we're advancing. And second, challenge in differentiating closely related Gleason grades. Am I surprised? Not at all, because they used human ground truth to train these things. And whenever it's something difficult to visually distinguish by a pathologist, then the ground truth is going to be inconsistent. And when the ground truth is inconsistent, or when it's visually very, very similar, then the algorithms have problems with differentiating it. So yeah, I'm expecting these challenges. As long as we will have ground truth from people, it's going to be only as consistent as people. And and if you don't, I'll tell you, the concordance between pathologists, like across studies, if we reach 0.7, we're like, wow, we're so concordant. Usually it's less. And I see more people joining, so let me know where you are tuning in from. And we move on. Why didn't I decide? Okay, so the next thing that I chose for us is This is super cool something, because on Instagram, so whoever is joining from Instagram, look at the stories. There was a question in a poll where I asked, okay, which paper do you want me to review? And the options were, and this paper, which you clearly can see that one, weakly supervised deep learning models enable HER2 low prediction from H&E stained slides. Or the other question was, which I scrolled through, the other paper was, machine learning-based analysis identifies and validates serum exosomal proteomics signature for the diagnosis of colorectal cancer. So I asked, okay, which one do you want? And we had 30 votes, and 23 of those votes went for the HER2 low prediction. So let's look at the HER2 low prediction. And this is a paper by Renan Valiris from Sao Paulo, Brazil, et al., right? Group, whole group. And this is in breast cancer research. And what is the background here? Human epidermal growth factor receptor, HER2 low breast cancer, has emerged as a new subtype of tumor for which novel antibody drug conjugates have shown beneficial effects. So we're talking about HER2 low. Assessment of HER2 requires several IHC immunohistochemistry tests with an additional in situ hybridization test, ISH, and if a case is classified as HER2 2+, and they tell you what this 2+ is, and the 2+ is low because 0 is negative, 1 is I think still negative, and there's low and high, right? So there is this 2+ that is problematic. So of course, when we have like several IHC tests, which I don't know how many, like one, right? And then but then let's say you have IHC, and when it's low, you need to do ISH to confirm. Then you already have 2 molecular tests. One of them is fluorescence, so that's another level of complexity. So of course, if there was something that could streamline this, what would it be? Prediction from H&E, right? Everybody wants that. I want that, because then you don't have to do other tests, or you can do them in a targeted way, right? So that's what they wanted. And what did they use? They used a self-supervised, attention-based, weakly supervised method. It's interesting. Self-supervised, attention-based, weakly supervised, right? Method to predict HER2 low directly from 1,437 histopathological images from 1,351 breast cancer patients. So that's quite a lot of slides, quite a lot of patients. So that's nice. And they built 6 distinct models to explore the ability of classifiers to distinguish between HER2 negative, low, and high in different scenarios. And the attention-based model was used to comprehend the decision-making process aimed at relevant tissue regions. So obviously they had to classify it from the tumor. And our results indicate that the effectiveness of classification models hinges on the consistency, have we heard it? Consistency and dependability of assay-based tests for HER2 as the outcomes from these tests are utilized as the baseline truth for training our models. So here we have something that you could consider, well, it's not really human-generated truth because you have IHC and then you have the result from the IHC. Who creates the result from the IHC? The pathologist. So obviously, when there is a borderline case, is it low or negative, or is it like whenever it's a borderline? So what did they say here? Negative, low, and high, right? So probably between negative and low, it's tough to distinguish. And if so, I actually once was at a workshop for PDL1 scoring. Even though I'm a veterinary pathologist, when I was working for a company that would help pharmaceutical companies analyze human tissues. As a researcher, I was doing these scorings, and they wanted to train us to be more consistent on PD-L1 scoring. And so how does that work? For PD-L1, there are, like, depending on which antibody you're using, there is a threshold, like a cutoff. Below this cutoff, it's negative, and above it's positive, right? And the cutoff is, let's say, 10%. For one of those antibodies, it's 10%. And so they wanted us to be like more consistent around this 10%. And if you have access to comment, please comment. I'm gonna wait a little bit, like I'm gonna move on with this paper and wait for your responses. Like how, like percentage wise, how concordant were we? Like how many people in the room, and it was like, I don't know, 100 people, 200, 150, would say negative, and how many would say positive after like an hour of training that we were supposed to be more consistent? Like after this training, how concordant were we? Like however you want to put it in the chat, let me know, and I'm going to move on, and then I'm going to answer this question. So where was I? Okay, so everybody wants to skip tests or have less tests or have cheaper tests. So they want to do a computational test on H&E instead of doing either some mutations or IHC or something like that, right? So here, their problem was, so the result was the effectiveness hinges on the consistency and dependability of the ground truth. I don't see any answers. If you have, like, just guess, make an educational guess. Sometimes I also get the answers with delay. Make an educated guess. How many were below and how many were above the threshold? Like what the concordance was. But here they say, if you have consistent ground truth, then your predictions are going to be good. Okay, I'm going to tell you, it was 50%. Like half of the room said, oh no, it's negative. Half of the room said it's positive. And I'm laughing at this because it's kind of like a ridiculous ask that all the pathologists in the world are constantly being asked. And if I have Monica, I know I have a few pathologists on the line here. Let me know what you think about it. I know it may be like, it must be not mainstream thought, because if that was mainstream thought, then we wouldn't be made to score in that way. But basically, all the pathologists in the world are made to, like, guesstimate thresholds. And then, when it's very positive, it's easy to say that, oh yeah, positive, give the drug. When it's like totally negative, it's easy as well. But there's always this cutoff where you visually, as a person, as a human being, physiologically, are not capable of distinguishing whether it's 11% or 9%. So around that cutoff, it's basically guesstimation. And that's what they said here in this paper. Even though there is like possibility to predict something from H&E in the correct direction, and IHC also is a method that has a lot of variables to keep it consistent, even though it's a mainstream method used widely for diagnostics. It has a lot of variables. Okay, so that was it today. I skipped a few papers. Let me know if you have any questions regarding what we talked about today, regarding your thoughts on pathologist scoring relying on percentage estimates. Let me check if I have any announcements today. If you're interested in exploring SciSpace, you can do that too. I'm going to be exploring it and telling you about it. One update is that I'm trying to, I started reaching out to people because I want to organize an event about the immigrant doctors changing US healthcare. And that's going to be obviously pathology edition, because we're digital pathology trailblazers. And before I move on, I'm going to read Monica's comment. Yeah, borderline cases are always challenging. Second opinion is important, and the benefit should go to the patient. Totally. My problem with this is like, okay, second opinion, if it's quantification, like how are you, like, to me, the only way of a reliable quantification of something in the image is with the computers. And most of those tests are not relying on computers. So yeah, the majority, and that's also a trend that you're going to see in papers. Yeah, we should have a lot of pathologists agree, then obviously the evidence is stronger. And like Monica says, benefit to the patient always. So that is fantastic. Yeah, so the event is going to be around Thanksgiving, and it's going to be about what are immigrants doing in the American healthcare, focused on pathology. I reached out to a few speakers. If you are an immigrant doctor, regardless whether you're an immigrant in the US or an immigrant in a different country, let me know. Let me comment IMG, IMG. If this would be something you would like to join, let me know, because I'm going to be putting up a registration page together, and I want to invite many prominent pathology movers and shakers that are from abroad. I very much relate to this because I'm from abroad. So that's what I'm going to be doing. And at the beginning, I already said that the podcast, this is going to be available as the podcast. It's audio only, and the audio only is also available on YouTube. So the channel, the Digital Pathology Place channel, had I don't know, 370 videos. Now that I added all the audio podcasts, it's like double that. And the podcast comes like from my podcast host, so it's only audio. So if, I'm going to be sharing videos on the email list. So now that we are 10 DigiPath Digests in, I'm going to stop bombarding everybody who is subscribed to Digital Pathology Place, which is currently over 8,500 pathologists and digital pathology professionals. I'm not going to be sending you emails every time I go live. I'm going to send a survey who is interested in getting those emails that you can join live directly from your inbox, which is something I personally use very much when I register for other webinars as convenience. But I know that people are busy, have inboxes that are super full. And if you get like 3 emails about, hey, I'm going live in 15 minutes, if you are not planning to go to this live, then it's irrelevant for you. So I'm going to send a survey about who wants to get those emails, and those of you will be getting those emails. And other than that, you're going to be hearing from me more or less once a week about the content that I'm releasing. So about the educational video, about the podcast that I'm doing. Every now and then there's going to be something additional. There are going to be promotions when I release new products, or when I organize events like the Immigrants Changing American Healthcare. But other than that, I want to be respectful of your inboxes, give you a piece of valuable content once a week. And maybe I'll send a few surveys if somebody wants to hear more often than that. And I'm going to be including some information in the PS section of the emails if there's more announcement than just one. Thank you so much for joining me today, and I talk to you in the next episode. Which is not going to be next week. It's going to be in 2 weeks, because next week I'm traveling back to the US. Amazing to have had you here. Bye.